If I put food into my mouth and it goes into my stomach and my GI tract, no matter what the food is, it's going to drive inflammation because inflammation is the body's natural protection against foreign material. Fructose, when it's metabolized, detoxified by the liver, it's handled the same way or in a very similar fashion to alcohol. It produces fat and it damages the liver eventually and drives this fatty liver disease. Stress is not what happens in the world. Stress is how we respond to what happens in the world. And stress is affecting our inflammation. Directly drives inflammation, drives insulin resistance, all these things. I was blown away by the fact that both physical exercise, but also mental exercise could show within a short amount of time actually changes in the brain, presumably related to its effects on BDNF, brain-derived neurotropic factor, which, certain parts of the brain, like you'd expect, the hippocampus, can actually increase in size with these various activities. So it's really amazing.
Rob, as a conventionally trained doctor who later went on to teach other doctors, I'm curious, where along that journey did cracks start seeping in that what you had learned might not be totally right?
Thanks, Jesse. It actually came all of a sudden. Just my background. I've spent my whole career as a professor in couple different medical schools here in Southern California. So I got to practice medicine, teach, do research. The point is, I represent the establishment, the medical establishment. I'm not a fringe doctor. I'm not a conspiracy theorist. I drank the Kool-Aid. I'm mainstream. But what happened to me, which is what happens to many people in this path, I came down with 4 chronic diseases sort of suddenly, hit me like a train. And I went to my doctors and they prescribed me medicines for them, prescription meds. And they assured me I needed to be on those for the rest of my life. And I knew that wasn't going to end well. So that was really what prompted me to begin an inquiry and re-examine my beliefs about the way things worked in medicine. And it was really a revelation.
How far back does that go when you started to get sick and accumulate these medications?
Yeah, it was about 10 years ago when it happens. And it happens to a lot of people when they reach a certain age. Most adult Americans are obese, many, half have hypertension, most are diabetic or pre-diabetic. So these chronic diseases are coming on to all of us, but they all happen right about the same time. So,
and unfortunately, a lot of people who go down your path end up on medications like you talked about for life and don't know of another way. So I'm just curious, where, as a doctor, obviously you have a little bit of a different world than a layperson. But what was it for you specifically? You're taking these meds, it's controlling the symptoms. What was that crack for you where you saw, maybe there's a different path here?
Yeah, the part of it was the diseases I knew that I had, which were gout, hypertension, dyslipidemia, and prediabetes, which are common diseases that everyone had. I thought they were very separate diseases. I thought they were being controlled by the prescriptions, but knowing what I know about those diseases, the future, at least as far as longevity, didn't look great for me. And I still have kids that aren't even in high school yet. So I wanted to be able to, out of self-interest, really, it forced me to look for other options just to see if there was any other possibility to an alternative to what I was doing.
So what were the first steps for you? What part of the alternative health realm did you stumble into and start to make changes in to work your way back?
Well, as it turns out, a friend of mine is Gary Taubes, who is a science writer, and he was writing a lot of books about Nobel laureates and all, but he had just transitioned into writing about nutrition science, and he was writing a book called Good Calories, Bad Calories, but we really didn't talk about that, and I really wasn't paying attention to his work. But one of when this happened, I sort of went back to his book. I looked at Nina Teicholz's book, a great book on saturated fat, and just I began looking at the more current research that I wasn't necessarily on top of, and many of my colleagues at the medical schools and certainly the doctors I went to weren't on top of either. And I began to see that there was a lot of new understanding and new approaches to these diseases that I wasn't told about.
You touched on something there when you're telling your story about the different chronic diseases. The fact that you felt like these were all from different areas and they were separate silos. One of the positive messages through what we're going to get into today is that there's a common root to disease, chronic disease. And when we apply some pressure on these different levers we're going to talk about, we can begin to correct for everything at once. So it's not very siloed, like I said before, where we need to look at symptoms and then how do we whack that separate symptom? We're going to get to the root of things by what we're going to get into today.
Exactly. And that was one of the revelations to me, certainly, that these diseases were certainly integrated, not only the 4 diseases that I came down with, but as we'll see, the many, many diseases, the diseases that statistically you and I and most of your listeners will die of is a very short list. And it's, things like cardiovascular disease, Alzheimer's disease, cancer. But it blew my mind to think that all of these diseases, there were common root causes that when you begin to improve one, you improve your chances with all of them. And it's something that I don't think mainstream medicine is still on top of it. And this message is not getting out there as it should.
Well, let's talk about this common root, which is metabolic dysfunction, what that is, and then we'll get into different ways to improve that.
Yeah, absolutely. I guess the model one model that I've heard that I like to repeat is the diseases I had were seemingly unrelated. I had arthritis, and then I had high blood pressure, and most people don't think of arthritis and blood pressure as being related. They're clearly different. And then diabetes, that's a whole nother disease. And that's the way our mainstream medicine is. But the fascinating thing is that, the metaphor, I guess, is that let's say I have a problem, and my problem is my floor is wet in my house. So I get a mop and I mop it up. And then another problem is the door is wet. There's water on the door. So I get something and I wipe the door off. But I'm treating the symptoms for these various conditions when actually the problem is not with the floor and the problem's not with the door. The problem is with the roof. And there's a leak in the roof. And the roof is sort of the metaphor for the root cause. And rather than taking prescription medicines for my blood pressure, my diabetes, my gout, all these other things, which I was told and I thought not only control the symptoms, but actually manage the disease. I thought, the disease was, quote, under control. But actually, what I learned is that they manage the symptoms, but frequently with many diseases, they block the symptoms, which is not necessarily a good thing because you forget you have the disease, but the disease goes on and continues to progress. And that's a fundamental problem. For example, with a heart attack, if you or I happen to go in the hospital, God forbid, to have a heart attack these days, where the blood flow is limited to our heart muscle through an obstruction in the coronary artery, which is the number one cause of death statistically for all of us, we will get what's called a stent, which is a mechanical opening of the blood vessel. And, for many people, it's like, wow, thank God I got my heart attack taken care of, done with that. I got a stent, all is good. When in actual fact, the stent only prevents me from dying on the table, perhaps. And studies have shown that stenting the blood vessel doesn't do anything to the long-term outcome of the disease. In fact, the cardiovascular disease, what's called atherosclerosis, continues to progress in all the blood vessels and even in the stent, unless I do other things. But the stent itself is just sort of a Band-Aid. And that's true for insulin with type 2 diabetes. It'll keep me from dying of an acute high glucose problem, but it doesn't control the long-term complications of diabetes or high blood pressure. I take blood pressure medicines, my blood pressure goes down. I think I'm done, but actually the damage to the blood vessels is continuing on in the background, but I'm just not aware of it anymore. My doctor doesn't care because not that he doesn't care, she doesn't care. It's that it's managed and the blood pressure's down. So the fundamental problem was that the approach that I was given was managing the symptoms, but to your point, didn't address the basic underlying metabolic conditions that were the root cause.
And as you explain these different areas and approaching it through symptoms, it gets me thinking about a microcosm of that, what the body does with insulin as our metabolic health degrades, and it tries to manage that blood glucose by making more and more insulin, and we become insulin resistant. So there's the overt taking insulin like you were talking about, but then the body also is compensating in its own way as our metabolic health degrades, which can take, 10, 20 years before full-on type 2 diabetes occurs, and all kinds of damage can be done in the meantime.
Yeah, absolutely. The whole metaphor or the whole disease of type 2 diabetes, my thinking really changed on that. I used to think that type 2 diabetes was like many diseases. As a doctor, I thought, well, you either have it or you don't. It's an on-off switch. And that's the way our healthcare system is set up for billing. When your audience has probably heard about hemoglobin A1C as a marker for diabetes. And once it gets over 6.5% in the United States, you're a diabetic. And if it's below that, you're not. You may be pre-diabetic, but it's sort of an on-off switch. But, to your point, diseases like diabetes and Alzheimer's disease and cardiovascular disease and all these diseases are present for years, if not decades, before the doctor will actually diagnose them in us. And it's really in our best interest to begin to address them in the prevention stage and not wait until the doctor says, yep, you've got Alzheimer's disease, you've got diabetes, because you really had it for years or decades beforehand. And the other thing about type 2 diabetes that my thinking has changed is there's a fascinating study that just came out with adult Americans without diabetes. These are healthy adult Americans. And if you plot their hemoglobin A1C, basically this blood test for diabetes, if you plot it over time, it goes like this. The older they get, the higher the HA1C goes. And what does that mean? Well, the way I think of it is it's like gray hair. In other words, hemoglobin A1C is going to get higher and higher, and diabetes is something that many, if not all of us, certainly many of us will get if we live long enough and don't die of something else first. In other words, so what does that mean? So when I make choices about my lifestyle, when I make choices about my metabolic health, I want to do those choices as if I were a diabetic, a type 2 diabetic now, because I'm already on the path to it, even if I haven't crossed the threshold where my doctor will, diagnose it. I'm en route to it.
If you're enjoying the episode, let me know by clicking like and subscribe below. Thank you so much. And now back to the show. Well, what I really like about your book is you get to the root of all this with mTOR or mTOR. So let's talk about what that is. And then when it's gone awry, it's not a bad thing in and of itself. It's something that we all need. But with the current diet that Westerners are taking in, high in carbohydrates, we're causing it to be triggered more often than we'd like. So let's take it all the way back to mTOR, talk about what that is, and then we'll work down to metabolic dysfunction, which then leads to all these chronic diseases. So it's all connected.
I love TOR. That's one of my favorite molecules. And actually, arguably, it's probably one of the most important biological switches that there are. Yet, the amazing thing is that mTOR or TOR wasn't discovered until the end of the 20th century. So, but we now know that it's conserved evolutionarily over billions of years. What does that mean? It's present all the way from yeast to human beings. So any molecule that's present in all those organisms has to be important at a very, very fundamental level. And TOR is, it's a simple thing. It's a switch. It's a biological switch that detects the presence of nutrients. And by nutrients, primarily glucose and oxygen to some extent, and insulin a little bit also. And when nutrients are present, it just instructs the cell to grow. So it's like a gas pedal. You turn TOR on when it detects nutrients, and the cell grows. And that's an absolutely essential thing for every cell to recognize, because if you grow when there are no nutrients, you'll die. Conversely, if there are no nutrients present, TOR turns off into the off side. And what happens then? Well, it tells the cell not to grow, but it also tells the cell to turn on something called autophagy, which is kind of repair, where it gets rid of older damaged parts of the cell. And it's actually a good thing. It's a healthy thing. So healthy organisms have mTOR turned both on and off. Both growth and repair are good. And your point you made is that modern humans have mTOR turned on all the time, or too much being turned on. And the reason is, arguably starting 12,000 years ago in the agricultural revolution, when we first began to domesticate plants. Before that, if you imagine hunter-gatherers, TOR would be turned on when you capture a buffalo and eat a buffalo, and then maybe it's turned off for a couple of weeks while you're hunting, and then it gets turned back on. It goes off and on. But beginning 12,000 years ago with agriculture, food became more and more available. And then it just rapidly accelerated in the last 20 to 40 years before that with refrigeration, and then most recently with junk food, which makes up the majority of our food supply now, to the point where people are eating all the time. And mTOR is turned on for most of us on the on side, which contributes to cell growth. Now, cell growth is important when we're young and our bones are growing, our brains are maturing. But there's a theory of longevity, which is gaining a lot of acceptance, is that turning mTOR on in this on state drives hyperfunction, and the hyperfunction actually drives the chronic diseases, all the ones that kill us. Cardiovascular disease is hyperfunction. The blood vessel wall proliferates and it's overgrowth. Cancer, of course, is a poster child for hyperfunction. Cells grow beyond control and they spread, they metastasize. Alzheimer's disease. Alzheimer's disease represents the ultimate failure of our medical research establishment. I mean, if you think about it, we've had decades of time to do the research. We've had essentially unlimited financial resources. And what have we come up with? There's no pharmacological intervention for Alzheimer's that has any effect. And even our understanding of what causes Alzheimer's is flawed. The beta amyloid hypothesis is really falling apart now. And there's reason to believe that Alzheimer's is driven by a type of inflammation and hyperfunction, among other causes, if you follow Dale Bredesen's work and all. And certainly metabolic disease, as we'll talk about, if we correct metabolic abnormalities with things like ketosis and all, we can actually reverse Alzheimer's disease like no drug can, and cause the brain fog to go away in some patients, not all patients, but and actually improve their function. So mTOR is fascinating. And the great thing about mTOR is we can influence it by our lifestyle choices. Certainly with nutrition, we can avoid foods that turn mTOR on, but also with sleep, with exercise, with stress, other things that turn mTOR on. And there's actually a drug that specifically targets mTOR, which many people are taking for off-label use for longevity. Although I wouldn't recommend replacing lifestyle changes and just say, hey, here's a pill. I don't need to do anything. This is a pill that's going to turn mTOR down. That's probably not the right approach for now.
Was I correct in saying that mTOR would be the root of chronic disease, though? And then it being triggered too much would lead to metabolic dysfunction and then chronic diseases like Alzheimer's and cancer. Do I have that right?
Yeah. I mean, mTOR is a major metabolic switch in a network of switches like AMP kinase and other things. But mTOR arguably is one of the most important ones. And when we turn mTOR on and nutrients are possible, I mean, if you think about it, when nutrients are possible, food is coming into the cell, foreign matter is coming into the cell. So what else does mTOR do when nutrients are present and it tells the cell to grow? It wants to protects itself, so it turns on inflammation. So when mTORs turn on, it's also an inflammation switch. And inflammation, as we'll see, is, as a root cause, one of the drivers of that metabolic disease drives, and vice versa, that causes all these chronic diseases. So to your point, we can do some interesting experiments with mTOR, because there's this drug that's a very specific drug that targets mTOR that will turn mTOR off into this healthier repair state, this autophagy state. And so you might think, well, if mTOR is so fundamental in aging and longevity, what evidence do you have for it working in anything at all? So there's some interesting experiments. If you look at, let's say, aging, the phenotypes of aging, right? I'm a poster for it, right? Wrinkles, gray hair, receding hair, periodontal disease, hearing loss. All these things are phenotypes of aging. We all recognize them. So the drug that is available is called rapamycin. It was discovered on Rapa Nui in the soil from a bacteria in the 1960s. And because of its discovery, they needed to understand what rapamycin worked on, and they found out this molecule. They named it TOR, which is, for lack of a better name, target of rapamycin. We could do some simple experiments. Well, in the mouse model for hair loss and gray hair with aging, you give rapamycin to these mice and the hair starts to grow back and the coloration returns. It's less gray than before. What about wrinkles? In humans, in a prospective trial, rubbing rapamycin on a double-blinded prospective rapamycin cream on the skin once a day for 6 months, these humans then underwent punch biopsies of both hands, and the rapamycin treated hand showed return of the collagen basal layers, and they were visibly younger looking skin with the rapamycin being applied to that. And interestingly, the FDA has just approved rapamycin cream about 12 months ago, not for aging or wrinkles, but for other cancer type diseases. But it's now being used off label for that. But the list goes on and on. You apply rapamycin to animals with hearing loss, with age-related hearing loss, and the hair cells regrow in the cochlea, and some of the hearing improves. You add rapamycin to there's one disease of aging that most people don't think of as a disease of aging, but it affects 50% of our population 100% of the time if they live long enough, and that, of course, is ovarian failure or menopause. So if this miracle mTOR affects something fundamental about aging and longevity, it should affect menopause too. So when they give rapamycin to the rats or mice, to the mouse model, it increases their litter size. They become more fertile, and they have a longer fertile window. In other words, it delays menopause. So for all these applications, there are now human trials in place for, I quoted a lot of animal studies, but they're beginning to look at humans things. So this is fascinating. I mean, these things all have different mechanisms if you think about it for aging, but rapamycin somehow gets to a basic root cause. But you may say, well, wait a minute. Nobody dies of baldness. Nobody dies of menopause. Nobody dies of gray hair. This doesn't really affect longevity. It sure may make us look younger, may make our skin better. But what happens if mTOR is so fundamental to our longevity? What happens when we apply mTOR to these diseases of aging that actually kill us? Like I said, it's a short list. Number one is cardiovascular disease, heart attacks and strokes. Number two is cancer. Number three is Alzheimer's. Okay, what happens with mTOR when we turn it down in those? Well, actually, we talked about stents before, the mechanical things that are put in blood vessels. When most people get heart attacks now, they get these stents. The problem with the stents, as we alluded to, is the disease continues and the other blood vessels continue to clot down, and the stents actually reclot off with atheromas over time. So what does turning down mTOR do? Well, actually, there's now an FDA-approved indication. If you coat the stents with rapamycin, you dramatically slow or even stop the atherosclerosis from occurring. So it's FDA approved to stop atherosclerosis. And there are studies underway where now taking oral rapamycin may slow down atherosclerotic disease in all of us. Okay, that's okay, great. It works for that. What about cancer? Cancer is a completely different disease, completely different different organization, different mechanism. Actually, if you let's look at a human model for cancer. Is transplants. You know what the most common cause of death? I didn't know this, but when I first started looking at this, the most common cause of death in a transplant patient, let's say heart transplants, within the first 5 years of getting a new transplant is?
No, I don't know.
I thought it was organ rejection or something, because that's what you're worried about when you transplant something in.
You give
immunosuppressive drugs. It's actually cancer, because the immunosuppressive drugs lower the immune system and people get higher rates of cancer. So
makes sense now that you say it.
Yeah. As it turns out, rapamycin, in fact, its first FDA approved indication is for helping with organ rejection. So there's a large population of patients who routinely get rapamycin for organ rejection. And then there's another group also who have transplants who may get something else that also works, but just isn't rapamycin. So, but what they found in this study was that in this population, whose human population is predisposed to getting huge amounts of cancer, when they're given rapamycin, the cancer rates drop by 50%. And now to the point where there are at least 8 FDA-approved indications for rapamycin for treatment for cancer, things like metastatic renal cell cancer, which is the most common type of kidney cancer, and other types as well. So it's like, whoa, something's going on here at a fundamental level. The last one is Alzheimer's disease, right? What evidence do we have that mTOR is involved in Alzheimer's disease? Well, there's an animal model for Alzheimer's disease that in the mouse, it's called the Mouseheimer model, where they actually get cognitive impairment. They forget their keys, their whatever the mouse equivalent is, and they have progressive dementia and everything. So when these mice are given rapamycin versus placebo, it actually reverses their mental fog and their mental acuity returns back towards normal, to the point now the University of Texas is having a trial go underway with rapamycin as a treatment for Alzheimer's disease. It's a multi-million-dollar study that's underway. But if you think about it, we talked about ketogenic therapies and all. Ketosis is really a way of turning that mTOR switch back to the repair mode, because the nutrients it senses is glucose. And when you're in ketosis or on a ketogenic diet, your body is burning, butyrate and ketones type substances rather than glucose. So your glucose levels are very low and your mTOR tends to turn back like that. But it's amazing. mTOR seems to play a role in these chronic diseases. And then, the last question is, well, is there any evidence that, fine, you can reverse the appearances of aging? You can reverse or slow the chronic diseases that determine my and your longevity. Is there any evidence to show giving rapamycin improves longevity itself, in humans? And the answer is there's no direct evidence, because it's very hard to do longevity studies in humans. Humans live, 70 years, very soon 100 years, and but the point is, it's hard to do longevity studies. But there's a gold standard longevity study that you may have talked about with your audience before, that's run by the federal government. They use mice. It's called the Interventions Testing Program, or the ITP. And the mice are great because they only live 3 years. So you could do a longevity study and know the results in 3 years. And the great thing about this longevity study, the ITP, is you and I as citizens can write in and suggest drugs to test. And what they do is they just take these mice they're not lab mice, they're actually wild type mice with genetically diverse appearance. They're in 3 different labs around the country, so it's not even one lab. And then they give them, half the mice just get raised normally, they live their lives and die. The other half get whatever the intervention is, typically the drug, the substance. And then at the end, they look at the lifespan of the mice. And is there a difference between the intervention and the regular mice? And, is there an improvement? Is there a longevity effect? And because we get to suggest everything, this has been around for 20 years. There have been some amazing thing tests that green tea, curcumin, NAD supplements, CoQ10, statins, all kinds of stuff that, that people wonder about for longevity. And the interesting thing is most of these had no effect. And there are only a handful of things that have an effect. And by far, the most powerful, most significant effect that knocks it out of the park is rapamycin. And one last nuance to it, when they did the rapamycin study, typically they give the drugs for the whole life of the mouse, which is not really realistic for you and I, because we're older and we don't get a chance to start it from birth anymore, and we may not want to. We don't know that that's a good idea. But for for the rapamycin trial, they messed up on making the food, and they wound up they couldn't get the supplements right. So the mice didn't start the rapamycin until they were the equivalent of 60 to 70 years old in human years, and even starting at that late age, they saw this dramatic longevity benefit.
Wow. So we've talked about a ton of positives. Any negatives?
Yeah, well, rapamycin, one thing, just to be clear, the very first use of rapamycin and the groundbreaking use for which it got FDA approval in 1999 was for immune suppression for renal cell transplants and other organ transplants. So immune suppression is a good thing if you have a transplanted organ from a foreign donor in your body. It's kind of a bad thing for you and I, to suppress your immune system, because immune system is important for all sorts of things. And most doctors, if you go to your private doctor and say, hey, I'm thinking about taking rapamycin for longevity, they'll go, whoa, no, you don't want to take that. That's an immunosuppressant. And so there's a lot of misunderstanding about rapamycin. To be clear, when humans take rapamycin, and it's FDA approved for a number of indications, but it's not approved for longevity, just because longevity is not an FDA indication, or it's not considered a disease or aging. When people take rapamycin for longevity, they typically do it instead of the daily dose, which is the renal transplant immune suppression dose. They do it once a week. And that once a week, the half-life of rapamycin is short enough, 48 hours, that it's gone in a couple days, or at least significantly decreased. So there's that misunderstanding about rapamycin. So there's a lot of uncertainty with physicians. But what about safety profile? That's a key point. Rapamycin is actually very safe drug. There aren't a lot of contraindications for it. There's a report in the literature, someone tried to commit suicide with rapamycin with over 10 times the recommended dose in one shot. They went into the ER and basically nothing happened. So the toxicity profile is very good. The side effects of rapamycin are the one thing some people note are mouth ulcers, little like cold sores or aphthous ulcers. A small percentage of patients get these. They're reversible. They go away, and they usually stop. But other than that, the biggest thing about rapamycin is we really don't understand it. We're just at the beginning of all these things, and it's a little bit of the Wild West. Even the dosage that people take, it's almost arbitrary. The dosage that we take, there's not a lot of data. It's still coming in, so it's kind of a leap of faith to take these drugs. I think the message that I try and communicate, and I certainly practice it myself, is that rapamycin's powerful. It does work on mTOR, but something even more powerful is our lifestyle. And I would never take rapamycin before I did all the lifestyle stuff first, because why is that? Rapamycin works, right? The ITP, done deal. Why not just take it? Well, some interesting results came out in the last literally 24 months. The ITP took another drug called acarbose, which has a small lifespan benefit. And when they combined, there's another drug called metformin, which people also take for longevity. Metformin had no effect on the ITP. That doesn't mean it doesn't work at all for longevity. Nobody knows, but at the dose it was given, if something fails the ITP, it just means that dose it didn't work. It's like if you take an antibiotic, if you take too low a dose, it won't work, but that doesn't mean it doesn't work theoretically. So metformin failed the ITP, but when they combined metformin with rapamycin, they got an even greater effect than rapamycin alone. So there's some synergy with, AMP kinase that metformin affects with rapamycin. But my point was, about 12 months ago, they published a paper where they combined acarbose with rapamycin. Acarbose has a small benefit in the ITP. Rapamycin has a huge benefit. When they combined the two of them, they got a greater benefit than either one of them separately. So there's some kind of synergy that we just don't understand. So rapamycin may be a great idea for longevity, but if you want to cover your bets, I would do longevity. I fix my diet, my sleep, my exercise, stress, all those other things as well, because otherwise you're leaving a lot on the table and you can miss out. And rapamycin or whatever longevity stack you use will likely be potentiated by your lifestyle.
And when it comes to rapamycin, is it totally downregulating mTOR? How much of an effect does it have? Because we know mTOR, again, isn't bad or good. It's just regulating how often it's activated. So what kind of effect does the drug have on mTOR specifically?
Yeah, that's a great question. Unfortunately, nobody knows. We don't have they're not good molecular markers in a clinical sense for mTOR. If I do NAD supplementation, for example, I could check, with if I do NMN or, NMR, I can check my NAD levels. With mTOR, there aren't easy clinically accessible indicators of that. We know from the science that it's affecting mTOR and these downstream effects, but there aren't easy indicators. So when I take my daily dose of mTOR, or my daily dose or my weekly dose of rapamycin, people say, "Well, how do you feel?" I say, "I feel great, but I'm also fasting. I'm, exercise. I'm doing all sorts of other things. So it's hard to tell what the actual effect is. And it's not like I stop it and I feel bad, or I take too much and I get side effects. It's really a black box, and that's the challenge with this particular longevity drug. It's both good and bad, but it's something that we'd like to, hopefully in the future we'll know much more about it and get better indicators that we can follow that it's working, and figure out even what the right dose is,
So you're taking it on a weekly basis. How long have you been doing that for?
I think I'm going on 3 years now. So,
well, let's get into diet specifics. Talk about what we can eat specifically to downregulate the mTOR and when we're eating. And you've mentioned ketosis, but let's get into how all that works, the physiology.
Sure. Yeah. I mean, before we get into diets with nutrition, I mean, there's one thing people can do that I talk about in the book. Even if you don't want to change what you eat, you say, "Forget it. I'm not into diets. Is there anything else I can do with my eating?" And actually, the answer is yes. Just by changing when you eat, you can improve your metabolic state and turn down mTOR and do different things like that. And that is to eliminate snacking. I mean, my mom was a dietitian, so I was raised on the misguided idea that, you eat many small meals throughout the day and all that. So instead, what I recommend is, start off when you get done with dinner. What I did, I brushed my teeth immediately because I'm basically lazy, and I knew if I snacked again, I'd have to brush my teeth again. So I just do it that way. And then, eliminate snacks between meals. And, if you're feeling really, if you really want to do something, you can eliminate breakfast, skip breakfast if that works for you, or even skip lunch. That's what I do. And I have one meal a day with my kids when they get home. And I'm basically fasting most of the other time. I drink, I have coffee or water, but no calories during those times. So that's the first thing you can do. Eat, just narrow your eating window, because when you're not eating, nutrients are not coming in, inflammation is going to be turned down. Just because, if you think about it, a lot of things affect inflammation. We talked about mTOR, but even eating itself, if I put food into my mouth and it goes into my stomach and my GI tract, no matter what the food is, it's going to drive inflammation, because inflammation is the body's natural protection against foreign material. And food is foreign material going in. So every time I eat, I'm turning on inflammation. If I eat all the time, or all the time I'm awake, inflammation will be turned on all the time. So even narrowing the eating window is a way of turning down inflammation. And depending on how long that window is, you may even get into ketosis and a favorable metabolic state there. So that's the first thing. Second thing you could do without changing what you eat that's going to help your nutrition, that helped me, was to think about macronutrients. Your audience, I'm sure, knows that, proteins and fats are the two essential macronutrients. We need to have those. We'll die if we don't have them. The third macronutrient, of course, carbohydrates, we don't need. It's non-essential, and there's several human civilizations that exist without significant amounts of carbohydrates at all in their diet. And as it turns out, carbohydrates are the things that drive insulin more than the others. They turn on mTOR more than the others. And even if you want evidence of how potentially problematic carbohydrates can be in our diet, that drug acarbose that I mentioned, that potentiates the effect of rapamycin in the longevity ITP program, the way Acarbose works, it's really interesting. It's an FDA-approved drug, but it's for diabetes. It's for type 2 diabetics and type 1 diabetics as well, I think. But it's not absorbed really significantly in the body. And the only way Acarbose works is in our guts, and it blocks the absorption of carbohydrates. So it slows carbohydrate absorption. And at least in the animal model, taking Acarbose, slowing carbohydrate absorption produces a longevity benefit. So you can do the same thing or get a similar effect. In other words, slow carbohydrate absorption. If you think of carbs as the enemy or what you want to avoid, but I have a meal here in front of me with a bunch of pasta and maybe some cheese and something else, I know that rather than eating the carbohydrates first, which will on an empty stomach, spike my glucose and have rapid absorption, I can get a similar Acarbose effect by eating fat first, maybe having the cheese beforehand or the olive oil with the salad, and that will coat the lining of my gut, maybe some protein as well, and save the carbs for the end. And that will delay the absorption of the carbs, and the harmful effect of the glucose spikes will be mediated. So those are two things you can do nutrition-wise before you even touch what you eat.
All right. So cutting down on snacking, narrowing the eating window, and then eating fats before carbohydrates.
Yeah, fats and proteins. Either one will block it. So then becomes the what to eat, and that's an interesting thing. I have let me say first that I have no dog in the diet game. I love my vegan friends. I love my carnivore friends. In fact, I was a vegan for like 10 years at one point. I've been a carnivore for a while. I think we can all be healthy or unhealthy on a vegan diet or all the way to a carnivore diet. It's just the choices we make in between. And there are pitfalls with each of those diets. I think there are a lot more pitfalls with a vegan diet. There's a lot more vegan junk food than there is carnivore junk food, but it's present in each one. But so I welcome. You don't have to switch your type of diet. It's just the food you eat within that diet. So the main thing I avoid is junk food. And I have to say, full disclosure, I'm a recovering junk food addict. I love junk food. I can't keep it in the house. I've got a teenager and a younger daughter, and they are continually trying me. But I find, just like an alcoholic, I don't keep liquor at my desk. I don't keep it in the house. Same thing with junk food. So everybody agrees junk food's bad. The question is, how do you define junk food? And that's a problem, because you have organizations like the American Heart Association saying that, vegetable oil is heart healthy. And I don't agree with that. I think it's not heart healthy. So the key thing is defining how you define junk food. So for me, there are three things that I look out for. In general, just in generalities, junk food, some things that will let you know that something's junk food. It typically comes in a box. It's frequently brightly colored to attract children. It has a long ingredient list. But specifically, the things that I do are, first of all, carbohydrates. Because of the things we talked about with insulin stimulation, I try to keep carbohydrates to a minimum, especially refined carbohydrates and sugars. So I have to watch out with fruits. Modern fruits are very rich in sugars, unlike the fruits that our ancestors ate, 10,000 years ago. Also things like starches. My wife's Chinese, so she grew up on rice. That's part of her cultural legacy. So rice is out, any of the starches that break down into glucose. So first thing is just to eliminate carbohydrates as much as possible in my diet. Once I've done that, The second thing I also watch out for is something called industrial oils or ultra processed oils or seed oils. They have a healthy sounding name called vegetable oils, but they don't contain vegetables. And in my opinion, they're not healthy at all because they drive inflammation and make all the diseases we're talking about worse. So these are, I'm sure you've talked about them on your program, but these oils, the problem is, the more I began looking at it, these oils are in nearly every single salad dressing that's available. They're in mayonnaise, they're in hummus, they're in all the junk foods. Why are they in the junk foods? Because they're relatively stable and they don't degrade over time. They're very cheap, so you can replace more expensive butter that turns rancid with these seed oils, and the food lasts longer. So seed oils is the second thing, and so it's basically carbohydrates and seed oils, and the last thing is sort of counterintuitive, and I certainly wasn't expecting it all. Was grains, even whole grains. And why is that? I don't have celiac disease, which is a disease that some people have that's gluten intolerance. But I believe, like many experts do, that much of the adult population are allergic to proteins in grains, if not gluten itself, but other proteins. And this allergy drives a low-grade inflammation that we may not even be aware of. It may manifest as irritable bowel disease. It may manifest as anger or depression. It may manifest as brain fog. It may manifest as exacerbating any of the diseases. So for that reason, I don't eat grains. Also, in the United States, grains are soaked, most of them, in a weed killer called glyphosate, which at least 34 countries around the world have banned for health reasons, but we still, our grains are soaked in it. And then the last thing is grains. Most grains have a large amount of carbohydrates, so that they're ruled out for that reason. So when I avoid those three things, I'm pretty much on the path to healthy eating, and it helps me with my fasting, because people say, how can you go and only eat one meal a day? What kind of iron willpower do you have? Well, I don't have iron willpower, but when people go into ketosis, their appetite decreases, and it controls your appetite and allows you to go longer periods without craving food.
And do you test for ketosis? Because the way you eat one meal a day, controlling carbs, I'm curious if you're going in and out of it or just staying in ketosis.
Yeah, the urinary tests are not that great. You can test your blood urine for markers, but that's not good. That's not that useful for ketosis that I found. You can do a blood test, stick your finger, but I hate sticking my finger. So I had a breath meter from one company that you blow into, and it detects that. And I check it for a while, and I'm reliably in ketosis. And so the short answer is no, I don't check it. I don't check it routinely every day, because I'm pretty much doing everything I could to be in ketosis, and there's not much more I could do. I can't push the accelerator down much more.
But that is the goal, though, to be in ketosis 24/7.
For me, it is, and it's not for everybody. Everybody has different things, but the amazing thing is we're finding that this metabolic state, which an indicator is being in some form of ketosis, is it basically reverses seizures. We know that's the oldest application for a ketogenic diet, is stopping seizures, and it's still being used today. Putting people in ketosis will reverse mental illness. Not everyone, not all mental illness, but as Chris Palmer and Georgia Eade have shown, some patients with psychiatric psychosis, manic depression, to the point where they're hospitalized, on medications and they no longer have a job and they can't be with their family. When Chris Palmer put some of the patients on a ketogenic diet, many of them are now going home and some of them off all medications. And there are now independent studies. One just came out at Stanford doing just that. So something about ketosis helping in mental health. And I asked Chris Palmer, he's a psychiatrist at Harvard Medical School, McLean Hospital, who's written a book about ketogenic diets for psychiatric conditions. I said, Chris, it's great, but how do you know it really works? Give me an anecdote. And he says, well, one of my patients, Bill, he was in the hospital with psychosis, schizophrenia. And the hallmark of schizophrenia, your patients may know, is we hear voices. Voices talk to us. A schizophrenic patient will frequently have those. So when Bill went on this diet, Chris was able to stop all his medications and literally send him home. And he's back with his family. He now has a job. And doesn't work that way with all patients, but even any patients. And there's a significant portion where it does. So Chris said, he goes, yeah, Bill knows that he says he knows that when he slips and has a piece of junk food and he starts going out of ketosis, he knows he's out of ketosis because suddenly the voices will start talking to him again. And as soon as he goes back into ketosis, the voices stop. So it's something about this metabolic health, which ketosis is one path to it. But for Alzheimer's disease, people drink exogenous ketones like MCT oils, or even going into ketosis can, for some patients, again, not all patients, have dramatic effects on Alzheimer's disease, which is really, untreatable. There's Heather Sanderson, who you may have had on your program. She runs she's a physician, runs a group of nursing homes around the country that specialize in Alzheimer's disease. She's a protege of Dale Bredesen, who's written extensively on it. But her nursing homes are unlike any other nursing homes that I'm aware of for Alzheimer's disease because the patients actually go there and they get better and then they go home. Most patients, sadly, my mom just died of Alzheimer's disease. Most patients with Alzheimer's disease, it's a one-way street. You go in and you get worse and worse and worse, and you eventually die. Well, I talked to Heather about, what's her secret in these nursing homes, and she does a number of different things, a big program. But one foundation is the only type of food they serve in the nursing home is a ketogenic diet. So it's, high in fats, healthy fats and meat and eggs and things like that. And they avoid the foods that I just mentioned that I avoid there. So I said the same question to Heather. I go, oh, that's great. You do the ketogenic diet, but how do you know it works? Do you have any evidence for it? And she said, well, yeah, there's Mr. Jones. I know that the ketogenic diet's working for him because when he's in ketosis and his grandchildren come in to see him, he smiles and hugs them and remembers all their names. But when he goes out of ketosis, the same thing happens. They come in the room and he doesn't recognize them and there's nothing happens there. So the point is there's something about this ketogenic diet that affects not only mental health and Alzheimer's disease, blood pressure. We've talked about, there's evidence that ketogenic diets now being used in certain types of cancer for adjunctive treatments for cancer. There's evidence that the ketogenic diet also affects cardiovascular disease. And as we talked about with mTOR, mTOR and rapamycin is one method to being metabolically healthy. And ketosis, if a ketogenic diet's for you, it's another path to get there, or even something to do in addition to your rapamycin or whatever you're doing. So these all are working at some basic, primitive, primal mechanisms that help our health and longevity. It's just fascinating, I think.
You talked about MCT oil there. Do you personally use MCT oil or exogenous ketones? to bring you, I guess you're always in ketosis, but do you use them as an adjunct or do you recommend them to people?
Yeah, it's a great question. There's a lot of good work being done on MCT oils. Dom D'Agostino, our friend, is working on those and all, and they famously have some dramatic results with Alzheimer's disease. Like literally, it's this woman. She was a physician. Her husband had Alzheimer's disease, severe mental problems. She started feeding him MCT oils and other exogenous ketones, and was able to reverse his disease and bring him back essentially significantly. And the only reason she thought of it because she was a pediatric neonatologist, essentially, where they were familiar with MCT oils and certain applications there. So yeah, it works there. I was just with Chris Palmer at a conference a few weeks ago, and someone from the audience asked Chris, so what about exogenous ketones for psychiatric conditions? And Chris said that, at least in his experience, and he's not aware of any case reports, that while they do work in, like, Alzheimer's disease and other things for these mental health conditions, he's not aware of exogenous ketones doing that. So it may be some benefit you get from nutritional ketosis versus exogenous ketones. It just shows how much we have to learn by this whole thing. But it's just fascinating, all the possibilities out there. And I mean, the one thing from Chris's work and is that all of us who, it's great for mental health, right? But most of your audience, me and you, are probably not going to be diagnosed with a clinical mental illness in our lifetime, statistically. But on the other hand, we're all human, right? We all go through ups and downs with our wives, our spouses, our children, our coworkers, our friends, our employees, our bosses. We all get angry. We all get anxiety. We all get stress. And you can't help but wondering what possible benefit improving our metabolism through, one of these approaches with mTOR or ketogenic diets could have just on society in general, the way, we get together. I mean, famously political organizations now, the Republicans don't talk to the Democrats and vice versa, when 30 years ago, it wasn't that way at all. The world is changing in subtle ways about the way people get together. And junk food is amplified in the last 30 years and driving all these things. I wonder if it's driving the way people get along with each other. You can't help but wonder that question.
So when it comes to your diet, there's 3 different pieces: the seed oils, the no grains, and lowering of carbs. For you, ketosis, you take that down to that level. For somebody that wants to use these guide rails, 2 of them are black and white, but the low carb piece is a bit gray, depending on if they want to go all the way down to ketosis or not. For the average person, would you say that's the goal to get to ketosis, or just to lower the carbs? And then expand upon that, things like fruit. And it sounds like you're not having any fruit, but for people that are more metabolically healthy, is that okay? How do you look at that whole gray area within the carb realm?
Yeah, I do have fruit. So once in a while, but I'm aware that it has, high fructose, and there are downsides to that. There's a whole discussion around that. But I think the goal necessarily isn't ketosis for everybody. It's not for everybody. But to be clear, there are people who are in ketosis their entire lives. I was just talking to a patient of mine whose daughter has had epilepsy since birth, and none of the medications worked. None of the surgical options were possible. And she's been on a ketogenic diet her entire life, and that's the way she stops her seizures. So it is, it's possible to be on this. But anyway, I think the goal is to be metabolically healthy. How we get there are different ways. And if you want to be in ketosis, I like fasting. I have my brain fog goes away. I feel better now than I did when I was snacking all day long and, having a big lunch and then falling asleep in meetings and stuff like that. So it's just, you have to look at yourself. But I think the goal isn't ketosis, and ketosis isn't for everybody, but you can use the ideas from it by cutting back your different things. And of the three things I do, it's interesting. I think it's important to note that they all have a different time scale as far as the effects. And so if you cut out sugars and cut out carbohydrates, you can see the effect in 24 to 48 hours. There will be an effect on your body. You'll begin noticing things. Cutting out grains, though, you have to wait longer because the effect on the immune system and all, typically you gotta wait about 3 months. So, I have people who go, hey, I cut out all grains for a month and nothing happened. So, it doesn't work for me. But you need to wait longer for that. And the bad news is with seed oils, it can be the half-life of seed oils, because they're stored in our fat, could be even years. So, it could be a long time before you see the results of those. But in my opinion, seed oils are really the only reason people put seed oils in food is for convenience. And cost in some cases, but there's no taste advantage of seed oils. Nobody says, I like canola, I want some Crisco, I want some vegetable oil. So that should be an easy substitute. If you're willing to make the effort to exclude those from your diet, you can do that. Things like carbohydrates, though, are different. There are tastes that are activated, sugar that's activated. Grains the same way. Baked goods. I love baked goods. There's nothing I'd rather have than, bagels and baked goods. There's only one thing I love more than baked goods, and that's my children. And I want to live to see them, and I want to live to see my grandchildren. So you could make those, we all get to make those choices ourselves. So, but it's all a matter of degree. And I'm trying to illustrate maybe an extreme case with me. Everybody doesn't have to be as extreme as I am, but you could take what you want from what I'm doing and apply little bits and pieces of it in your own lives, and hopefully you'll get a benefit from it.
One area you drill deep into in your book is fructose, which is under the carb realm, and fatty liver. So let's talk about that connection there and the physiology that happens in the body when we're consuming too much of that.
Yeah, our understanding of fructose has dramatically changed in the last few years. It's fructose, as your audience may know, it's one of the primary sugar molecules. Glucose and fructose, when you combine them together, make sugar, table sugar, sucrose. For many years, fructose was felt to be the good sugar. In other words, unlike glucose, if I eat glucose and have my rice or my carbs, my insulin will spike and my glucose will spike in my bloodstream. If I eat pure fructose, which happens to be a sweeter molecule than glucose, so it actually tastes sweet. If I eat pure fructose, my insulin doesn't spike and my glucose doesn't spike, to the point that the American Diabetic Association, which is not an organization to be trusted for all sorts of reasons, we can get into later if we want, but they used to recommend that diabetics substitute fructose for glucose and just eat fructose because, hey, it doesn't affect your insulin, it doesn't affect your glucose. It's a safe alternative and it tastes sweet. The problem is fructose is it's exactly the same chemicals in fructose, carbon, hydrogen, and oxygen, but they're just, as in glucose, but they're just rearranged slightly. So they're very similar that way, but they're handled completely differently by the body. Every single cell practically in the body can utilize glucose for energy. Fructose, no cells in the body use it except in the liver, where it's essentially detoxified for most of the fructose in our body. So the liver is a detoxification organ. That's where alcohol goes. When we drink alcohol, it goes to the liver and it gets detoxified there. And it used to be up until 1980 that when people damage their liver, they get what's called fatty liver disease. And the number one cause, if you had fatty liver disease, you were most likely to be an alcoholic or have alcoholic liver disease. That's what it was called, alcoholic fatty liver disease. And something strange happened. A new disease appeared in 1980 that had never occurred before, and to the point it's now the number one liver disease, the number one cause of liver transplants, but it didn't exist before 1980 largely. And it looks just like alcoholic fatty liver disease, to the point that patients would come in, they'd be diagnosed with these damage to their liver, and the doctor would go, "Oh, you've got alcoholic fatty liver disease. You need to quit drinking." And the patient would go, I don't drink. I've never drank. And the doctor would say, "Sure, but just stop it." Whatever, And that created some tension there in the doctor-patient relationship until children started coming in with this fatty liver disease, and they were said, "Well, you've got alcoholic fatty liver disease." This is a 6-year-old child. They've never had alcohol. How can they have fatty liver disease? And anyway, what they discovered was that fructose, when it's metabolized, detoxified by the liver, which is the main place it goes, it's handled the same way or in a very similar fashion to ethanol, alcohol. And it produces fat, and it damages the liver eventually and drives this fatty liver disease. So what happened in 1980 so that fatty liver disease is now caused by fructose and not alcohol? Because if you look at the drinking rates for alcohol, it hasn't changed that much. It's pretty much the same. But something happened with the discovery of a compound called high fructose corn syrup, which is it's just a way of extracting something from corn that's made of fructose and glucose. It's similar to table sugar, but it doesn't have that chemical bond there, but it doesn't really matter. But the thing was, high fructose corn syrup became widely available, and it was placed in all junk foods. And it replaced the alternative, which was cane sugar. Cane sugar is sort of crunchy, and it crystallizes and doesn't have a good taste. High fructose corn syrup stays fluid. You can put it on the shelf for 12 years, like all good junk food. It'll last forever. And the other thing about it is it's subsidized by the government. Corn is one of the crops that is artificially lower in cost. So high fructose corn syrup is low in cost. So what happened? Everybody switched out cane sugar for high fructose corn syrup, and Coca-Cola, Pepsi, all the soda companies switched out high fructose corn syrup, and junk food just exploded. And this non-alcoholic fatty liver disease exploded to the point that now when someone comes in with a fatty liver, you don't ask them if they drank alcohol. But the problem is most of the medical establishment still considers it to be of unknown cause. It's vaguely related to metabolism. Even today, you hear that, although experts like Robert Lustig at the University of San Francisco did a prospective controlled study with children, and he basically he removed fructose from their diet and substituted glucose. And in a matter of weeks, he was able to reverse the fatty liver disease in these children just by removing the fructose. So there's tremendous evidence, in my opinion, it's caused by fructose. And if you want to, this is shown throughout history, because fatty liver it didn't start out as a disease. It started out as a culinary item with foie gras, which has been around at least since the Egyptian times, where the Egyptians learned to give geese fatty liver. And if they wanted to do that, they didn't give them alcohol. They didn't give them sugar or glucose, but they gave them things that had a large amount of fructose, figs in particular. And the same thing that's true today too. You don't feed them protein, you don't feed them fat, you feed them high carbs, especially fructose. So anyway, that's a rambling conversation about fatty liver disease. And I think the lie is that we don't know what causes fatty liver disease. And I think the evidence is overwhelming, and I've cited it in my book. These aren't my ideas. All I'm doing is reading the literature as I interpret it. But it's due, in the vast majority of cases, to fructose toxicity. And I think we all need to be concerned about fructose, even if we don't have fatty liver disease, that it's something to at least be cautious of. And one last point about fatty liver disease, it was usually only diagnosed when the liver enzymes, the liver blood markers, got very high. With CT scanning, it's possible to make the diagnosis on an X-ray image. And one interesting study where they scanned adult patients coming in for colonoscopy, which is unrelated to fatty liver disease. They just looked at all their livers, and they found upwards of 50% of them had fatty liver disease, but they weren't diagnosed. And then they looked at the radiology reports that the radiologist dictated, and only 10% were dictated of those as fatty liver disease. And then they looked at the follow-up of the radiology reports, and less than half of those had any follow-up from the referring physician. So it's not on people's radar yet. It's a marker for insulin resistance. It's a marker for inflammatory disease. It's a marker for metabolic health. All these things get tied together.
And the good news is, like you talked about Dr. Lustig's research, if it's caught early enough, it's reversible.
That's right. In all of us, hopefully, yeah, we could do that. And I mentioned it doesn't spike glucose, right? And it doesn't directly spike insulin. So you think, well, what's bad about it? Well, it drives insulin resistance in the liver. So even though the acute changes are not spiked, fructose in itself will drive insulin resistance. Fructose also converts to uric acid, which is a driver for gout. And it also drives the endothelial glycocalyx, which is the lining of our blood vessels, which drives hypertension and cardiovascular disease. It affects nitric oxide production, which controls those. So the sugar we eat can actually drive hypertension and cardiovascular disease through these mechanisms.
One of the things that typically happens when somebody adopts a lower carb diet, ketogenic diet, is they're going to have less plants in the diet, less fiber. And that would be one of the common arguments against going low carb, because we need to eat a lot of plants and get our fiber in, get our diversity of different plants. How do you look at fiber? Is that something you're concerned about with the way you eat? And how do you feel about it in general?
Yeah, I think fiber is good, especially non-soluble fiber that slows the absorption of the bad things in our gut. I don't think it's good enough that I should eat carbohydrates in order to get it. So I can eat low carb things that have fiber, like celery and relatively unsweet vegetables. I think are a good source of that. But personally, I think that the carbohydrates are a bigger danger to me than low fiber. But I do get fiber in my diet for sure.
If you weren't, though, would you be concerned? Because there's a group of people these days in the health space saying fiber is overrated. We don't need fiber. Would you take it that far?
Yeah, I mean, I don't exclude it just because I don't think the evidence is that strong that it's actually harming me. But I do agree that the value of fiber has been exaggerated. Like, many people were taught that a low fiber diet causes diverticulitis and, certain bowel diseases like that, when it's probably related to other things like inflammation and metabolic factors that we've been talking about, rather than the fiber in the diet.
And how do you feel about supplements? You've stated the perimeters of your diet. Following those, do you feel like they're essential? Is there any you're taking?
Yeah, I think supplements are, well, first of all, we want to correct any deficiencies that we have. So, you can eat the best diet that you want, but if you have a genetic issue with a methionine metabolism or folate metabolism or vitamin D, you may need to take vitamin D supplements, or you may need to take other supplements. So I think supplements are good to correct basic levels, and then going beyond that, correct deficiencies, basically. So going beyond it, it really depends on the supplement and what you believe in it. There's been a whole explosion about resveratrol and debunking that, which was a sirtuin activator that's very controversial. That's found in grapes that was popular 20 years ago. We've touched on the longevity supplements like metformin, or the non-prescription berberine has some of the similar effects. We've talked about rapamycin and some of these other things. So I think I would do those on a case-by-case basis, depending on your individual viewpoint, what you've seen to be valuable. And, the short answer is nobody really knows. And if anybody tells you they do, they're probably, I wouldn't trust them.
How do you feel about organ meats, either through supplements or whole food form, to add additional nutrients to the diet?
Yeah, I mean, when I was growing up, my mom used to feed us liver, and that was probably a good thing, one of the good things she did. But I get it in theory. In theory, I haven't gotten to the point where I'm taking the organ meat capsules, and I don't order organ meats a lot in the when I do it. But in theory, I agree with it. I haven't done a deep dive in it. I might draw the line at brains, certainly because of prions and that kind of thing. But in principle, I could see the value of those in getting nutrients, because hey, eating red meat, it's not as simple as that, or eating meat. It's about, what did the meat eat? And if they were fed corn, which most meat is fed these days, it's the same corn that's subsidized, it's cheap, and it's, unhealthy. So you want to, grass-fed, grass-finished, all those things. It gets really complex really fast. And if you just eat the muscles, then, like you say, you're missing the organs and different things there. So a lot of nuance and complexity.
And when you're buying meat, how much of a concern is it for you to get grass-fed, grass-finished, organic? Is quality a big concern?
Yeah, I mean, given the choice, I think organic is valuable in meats, and many of the produce, it's valuable as well. And I'll pay attention to those things for sure.
So we've went deep into diet, what you eat, when you eat. What are some of the other big levers we want to look at when it comes to metabolic health?
Wow. Well, one that completely caught me by surprise, it was unexpected. I mean, I knew it played a role, but I sort of underestimated the role, and that was mindset and sort of mental approach to things. And it's almost like the future we imagine, how we look at the world, how we envision the future, how we envision our future affects the future we will have. In other words, it's not just about, not being depressed, not having anxiety, which is certainly a big factor. We want to be healthy, but I think it goes above just the baseline being mentally healthy. We want to go beyond that and have a mindset of abundance and a mindset of having a purpose in our lives. I mean, it's no surprise that, many people retire, or many people die at age 66 in this country. And why is that? Well, that's because they retire at age 65 and they lose their purpose. I mean, what is it? Firefighters, most of them die within 5 years after retiring. I mean, there's some interesting statistics there about purpose. So I think the future we imagine for ourselves can be the future we create. In other words, if I look at older age as a time of infirmity, a time of decline, a time of impairment, it's nothing I look forward to, and there's a good chance it will likely become that for me. If I look at my life as age of abundance, a possibility of goals I want to accomplish down the road, there's a good chance that will happen. I mean, I used to make not a joke, but a comment about, talking about the phenotypes of aging, all the stuff like wrinkles and, gray hair that we talked about before. And I used to say, well, we could take Botox for wrinkles, right? I'm in Southern California, that's very popular here. I'm obviously not taking it, but I sort of made the comment, well, the sad part is that people who, you could take Botox for wrinkles, but people will eventually find out that taking Botox for wrinkles doesn't make you live longer. It doesn't affect your longevity at a core level. And then I began to have conversations with people, and they said, are you sure of that? In other words, and what they were pointing out is that people who embrace youthful vitality, they look at their life as, something happening long term, and they make the effort to, get the Botox, or they look at life as, powerful, rather than someone looking at it like, I'm dying, I'm going to die, and guess what? One of these days I'll be right. It's true, they will. People who look at it as a chance of empowerment actually may live longer. So people, getting the Botox, and it's about the mindset. I have a friend, I was talking to him, and I said, yeah, what are you doing this summer? He goes, I'm going to Burning Man. It's probably the last one I'm going to go to, though, because he's in his 70s. And I think, well, why? What's going on? Is it you planning on dying or something? And that was sort of the unspoken thing. Well, I'm old, but with that attitude, you are old. You will be old, But if it's like, no, I'm gonna go. I'm waiting. I'm gonna go on my 100th to the burn and do this or whatever festival or event you look forward to. That mindset plays a role, and then I began to ask myself, like, oh, well, sure, that makes sense. How could it possibly tie in mechanistically? What? We're all evidence-based, right? We want scientific papers. How can we make a mechanism that ties in mindset to aging better? Well, one thing is stress, right? If we look towards our future life as a life of joy, abundance, accomplishment, and purpose, I'm going to do great things. It may be great things with my kids or my grandkids, or it may be great things for my charity or my job or whatever I'm doing. But looking towards the future as a place of abundance, it changes the way we experience stress, and stress is affecting our inflammation. Directly drives inflammation, drives insulin resistance, all these things. So how do we affect stress by our mindset? Well, stress is really interesting. This is another wake-up call for me that I hadn't thought of before. Is stress is one of the biggest drivers in aging and all these things through inflammation and these other factors. But stress, you ask people what causes stress, is, well, what happens to me in the world? It's the environment, right? I don't get to, pick the political candidates or, pick there's an earthquake or, stuff happens, and it's stressful. Well, that's true, sort of, but it's not completely true. Actually, stuff happens in the world, and we don't get to control what happens in the world, right? But stress is not what happens in the world. Stress is how we respond to what happens in the world, how we, you, me, everyone else, individually responds to what happens in the world. And so a similar thing can have a different response. When it starts raining, I could get really stressed out because my nice new clothes are ruined and It's a stressful experience. On the other hand, it's raining, it's warm, it's beautiful, it's glorious. I love it. I love the feel of rain. It's a beautiful moment. Or an extreme example, I have surgery. It's extremely painful. I'm extremely stressed out. The same amount of pain, a similar surgery could be a joyous experience to someone else who's having a baby, a lot stress we get to filter through our expectations, through our view of the world, through the reality that we create, and we get to create it through our mindset. And I think this is really underestimated, and it's really a overlooked opportunity in healthcare and longevity for all of us.
You mentioned inflammation there, tying the stress to health as a whole. Any other ties physiology-wise?
Yeah, I mean the stress. I mean, inflammation is the ground the ground truth on that, but also driving metabolic conditions like insulin resistance, inflammation, insulin resistance, metabolic disease are all interrelated. So I think it drives all of those as well. And just the stress really frames our reality. In other words, if I look at the future and it's very stressful, that's a very dark future, and I'm not happy about it. And maybe I don't want to live that long, On the other hand, if the future is joyous with opportunities, not that everything is happy, but if I look at it with a attitude, a mindset of growth, a mindset of abundance, it changes the way the reality appears, I think.
And pivoting off of stress into exercise, these two are tied together. Exercise being a modality we can use to drive down our stress. And also exercise is tied to metabolic health through even walking after meals, putting on muscle mass. So I'll have you bring exercise in and talk about how you use that personally and how people can use that as a tool for metabolic health.
Yeah, exercise is huge. And I want to divide it into two parts. The first is the obvious one, physical exercise. And then if we can come to mental exercise. But physical exercise is really important for all sorts of reasons. Exercise in itself is stressful. So, but it's a good kind of stress, and we react to it positively and all. One thing I wasn't aware of that was sort of a wake-up call, but maybe it shouldn't have been, is that exercise, like almost everything else we do, there's a good amount and a bad amount. In other words, low amounts of exercise, which most of us fall into, is bad. But there's actually some growing evidence that large amounts of exercise beyond a certain point can be harmful. So it's kind of a U-shaped curve. And the data came in with ultra marathoners, ultra athletes, where they actually have increased calcium scores and they have increased coronary artery calcium out of proportion to their age group or anything that they felt is tied to the stress of this exercise. But then you may say, well, maybe it's spurious, it's related to calcification, but it's not really heart disease. It's just calcification of the vessel, maybe due to flow or something. But then a darker part became revealed, and they actually have myocardial fibrosis and abnormalities of heart wall function, which is really concerning. So I guess the point is that there's a sweet spot for exercise. Most of us are not doing enough, but on the far extreme, we need to be at least aware that, we don't want to do too much, certainly to injure our bodies with our joints and everything else, but also there's a basic cardiometabolic factor going on there. So I think, that's important. Resistance training, for osteoporosis, muscle mass for glucose metabolism, just handling insulin, handling all these things. There's so many advantages of exercise and the physical exercise. I think that's huge. The mental exercise is sometimes overlooked with people, but I think it's equally important. What blew me away was that my training is in radiology. So, looking at x-rays and stuff like that. I was blown away by the fact that things like both physical exercise, but also mental exercise could show within a short amount of time, in a matter of months, actually changes in the brain, actual brain growth, presumably related to its effects on BDNF, brain-derived neurotrophic factor, which, certain parts of the brain, like you'd expect, the hippocampus, can actually increase in size with these various activities. So it's really amazing. But so for mental activity, it's not like watching TV or watching a movie, something passive, but ideally it's something active that's engaging your brain. I mean, if ideally you could do something that engages both physical and mental activity, like playing a musical instrument or something where you're, doing both is good. If you're not doing that, I just started doing a language, Duolingo. I can do it on my phone. It's a free app, doesn't cost anything. I do it 5 minutes a day. I'm now at 1,400 days, a continuous streak. And slowly but surely, 5 minutes a day, I'm learning Mandarin Chinese. And what I'm doing, the next level up if you're learning a language and you want to up your game, there's so many resources on the internet today. So what I did is I took Siri or my app on my phone, whatever your Alexa, Siri, whatever you use, but I just had it change into Mandarin only. So now if I say, "Hey Siri, set a timer for 15 minutes," it responds in Chinese. It says, "I don't know what you just said." So now it forces me, every time I interact with Siri, I have to do something that I have to, one, get my pronunciation right so that it works. So I say, "Hey Siri, ding chi chi arsha feng zhong," and now, sure enough, 20 minutes. So there are all sorts of things you can do like that if you're not into foreign language. Obviously crossword puzzles, Sudoku, those kinds of things like that. But mental stimulation, even just going for a walk and talking to your neighbor, engaging in community, engaging in, the blue zones were very popular for longevity a few years ago, and with certain parts of the country, certain parts of the world where people had very long life expectancies. And Dan Buettner popularized it with a TV series. And there were a lot of wonderful things about it. Community, certain types of food, getting together, working in the fields. But the sense of community, a lot of the other stuff has been criticized recently, like the record keeping probably confused the ages, and that was probably a thing. And then sadly, the whole Blue Zone brand has recently been sold to a group with strong religious affiliation, which has a strong nutritional agenda, which may influence the messaging with that. But I think there's a lot of good things to be said about community and family and social interactions with the Blue Zone theory, but that applies to the brain exercise anyway.
All right, tying into another piece that fits with the brain and with stress, sleep. Let's talk about its impact on metabolic health when we're getting enough and then when we're not.
Yeah, and I think this is a place where the medical profession is so messed up with this because, I, like many people in my profession or many other professions, I used to carry a beeper around, a pager, and I would be on call 24 hours a day, 7 days a week, and I'd get called at all weird hours. My sleep would get disrupted, but somehow I thought I was being tough and I was helping my patients when actually I was probably hurting them. And one wake-up call to me in this book was, in researching this book, was that, you hear some people like Elon Musk saying, "Oh, I only need 4 hours of sleep a night," There's a growing evidence that just like for exercise, just like for so many of the things, the the cost benefit curve for sleep, for quantity of sleep, is fairly narrow. In other words, it appears that risk of cardiovascular disease and other diseases, all these metabolic diseases that I've been talking about, is a fairly narrow window, around 8 hours, and so maybe some people can get by at 7 hours, maybe some people need 9, but if you need much more than that, or if you think you can get by much less than that, you may be kidding yourself. And sleep, we know directly with sleep deprivation, you take college kids, and there have been controlled studies with this. They sleep deprive them, and immediately their insulin resistance goes up. Their metabolism is messed up. Their glucose is screwed up. There's inflammation. So it directly affects these primal metabolic markers that we're taking. So the wake-up call for me was sleep quantity, which really helped. And then the other thing was sleep quality. So, you've got to get the right amount, but it's got to be good sleep. And there are a number of trackers on your phone or different things that you can do to look at that. I mean, an interesting thing happened to me once I began on this path and changed my lifestyle and everything. I noticed that I was sleeping a lot better. I don't know what it was. I wasn't paying attention to it, but I was sleeping a lot better to the point that I didn't need an alarm clock anymore. So I just sort of woke up naturally. And now I figure if I need an alarm clock to wake up, I'm probably not getting enough sleep. So it's fascinating. But yeah, sleep, I think, is another area that's overlooked in our toolkit for metabolic health.
You mentioned trackers there. For somebody who's tuned into this point and, they've taken in a lot of different information, different areas where they're wondering where they're at on this continuum of metabolic health, how does testing fit into this for somebody early on to see where they're at and then ongoing to continue to keep track of their progress?
Yeah, I think testing is key to know where we are on that course. And like we talked about, the earlier the better. I mean, these changes start happening in people's 30s, although these chronic diseases usually don't hit till people are 40 or so, although they're getting earlier and earlier. We're seeing now cancer, colon cancer, hitting in younger and younger populations, and obesity. Type 2 diabetes used to be called adult onset diabetes. Now it's occurring in children. Similarly, hypertension and everything. But so tracking early is good. Some of the markers I would look at is hemoglobin A1C, which is a marker for glucose damage. It's the metabolic marker for insulin resistance. You can do, you can absolutely measure fasting insulin. I mean, I use a panel that I do from, I do a finger stick at home. I get about 20 markers. I do it like once a month or two, and it gives me hemoglobin A1C, insulin, LDL, cortisol, testosterone, FSH, homocysteine. It's just a whole thing. And now these tests are getting so inexpensive and so easy. You can even do them from your home and begin to track where you are in this. And it's never too early to start thinking about metabolic health and to live a healthy lifestyle, because we don't know how early these things really start, and the sooner we engage in prevention, I think the better the outcome.
And what's the name of that test you were just talking about, the finger prick?
Yeah, I have it on my website. You can get it from a company called Sifox, SIFOX, but I have a discount on my website. It's about, I think it comes out to be about $15 a test or so, but it's significantly less than the Sifox site, but that's who we use, and it's a great one. So either on my website or at Sifox, either one, you can try it out.
All right, Rob, we'll link that up in the show notes. We'll link up your new book, your website, your social media, everything, and really enjoyed this conversation. The new book is fantastic. I was telling you before we connected, and I just want to thank you for coming on and sharing all this about metabolic health. It's going to help a lot of people. Thank you.
Yeah, this has been fun, Jesse. I just got my first copy of it. It's full of pictures inside, so it's
nice. I had the PDF, so
hopefully people enjoy it.
Yeah, no, that looks good. Congrats, and thanks again.
Thanks so much for having me on your program. It was a real honor.
Now that you're done, you're going to want to head over here and catch this next incredible episode. You don't want to miss it. I'll see you over there.
Everyone needs to care about this because metabolism and metabolic health, it is the core foundational layer that all health is built upon. That is the biggest blind spot in Western